So how many people in the room have done a primary posterior capsulorhexis? So we're going to talk a bit about indications, the technique itself, and then some complications. All children under the age of 8 undergoing cataract surgery, in my hands, will have a primary posterior capsulorhexis because they all get PCO. And under the age of 8, most of them won't be cooperative enough to sit at the slit lamp for a YAG capsulotomy. Some older children, those with learning difficulties, for example, might need it as well for the same reason, and some adults. So if there's severe scarring of the posterior capsule or dense posterior plaques, then sometimes a posterior rhexis is easier than a YAG capsulotomy where you'd need to use a lot of energy. And then while you're having complications during cataract surgery, I'm sure none of you do, but if you do, you sometimes have to manage the posterior capsule in such a way that you have to complete the posterior rhexis as part of that management. And then if you're doing bag-in-the-lens surgery, I'm sure you've all seen that from Marie-Jo Tassignon, where she actually does an anterior and a posterior rhexis and then sandwiches the two layers of capsule between the flanges of her specially designed lens, and she gets 100% no PCO because there's nowhere for the lenses to go, the lens cells to go. And sometimes you'll combine that with an anterior vitrectomy, particularly in children under 5, because if you leave the posterior rhexis performed but you leave the anterior hyaloid intact, then often they will have such aggressive cell growth that it can grow across the anterior hyaloid face. So they may need an anterior vitrectomy as well as a posterior rhexis. And here's an example of a posterior capsular plaque. And sometimes you can get these off with viscoelastic or with forceps, but more often than not, they're so tightly adherent that you can't move them. And you'd have to apply an awful lot of energy with the YAG laser to remove that. So sometimes it's just easier to do the posterior rhexis in the first place. And there are various techniques. Initially, the pediatric posterior rhexis was described by, or Ken Nischal described this push-pull technique, which I'll show you a diagram of. You can just use forceps, that's what I tend to do, but I use cross-action forceps. I'll show you a picture of those because they're much easier to manipulate the posterior capsule. And you can use the vitrector to, nowadays with the modern machines with a very high cut rate of the anterior vitrector, up to 3,000 or 4,000 cuts per minute, you get a very even, smooth cut of the edge of the rhexis. If it's a slower cut rate, it tends to be a bit ragged. So it's probably better not to do it with a vitrector, but it can be combined with a vitrector if you're doing an anterior vitrectomy. The needle, it can be used, it has been described, but there's really nothing to push against, and you are in danger of damaging the anterior hyaloid face if you go through the capsule with the needle. So I prefer not to use a needle for the posterior rhexis. So here's a diagram of the push-pull technique, and what Ken Nischal does is he makes a nick in the capsule here with a blade and a nick here, and then he just extends each of those nicks until they join up into a circular rhexis. And it's perfectly possible to do this. The thing to grasp is the diaphanous, thin, friable, delicate nature of the posterior capsule is a very different feel to the anterior capsule. And what you often end up doing is a modified little rescue technique all the way around because the tearing vectors are very different. With forceps, I think, as I said, cross-action easiest to control. It is important, again, to fill up the capsular bag so the cataract is out of the way. But filling up the capsular bags puts some backwards tension into the posterior capsule, and it helps you control the size of the rhexis. And these are the cross-action forceps, this particular pair made by Duckworth and Kent. The nice thing about them is that where they cross is where they go in through the wound, and because that's the smallest point, they don't open the wound as you open the forceps. So they're really nice for small incisions, and they're, because of the round handle, it's very nice and easy to control them with your fingertips. You can rotate them easily and manipulate them. They're very comfortable to use. So here's an example of posterior primary capsulorhexis in a pediatric case. So in this case, you can see the rhexis has been done, hydrodissection. It's just a nice visible hydrodissection. Nowadays, I tend to do a hydrodissection at 3 o'clock and at 9 o'clock, and that way, because often in an adult you can't see that edge, you know that both edges are going to be free. In pediatric cases, I still use a phaco probe because they're sometimes surprisingly hard, but it's a really good aspirator as well. I've also found that you don't really need to suture them if you construct your wound properly. And putting stitches into small children's eyes is just another step. You then have to take them back to theatre, remove them, or use a dissolving suture, which causes a bit of inflammation. So I tend not to. And here we go, filling up the bag with the viscoelastic. This is a cohesive viscoelastic, and making sure the bag's nice and full. And then it's actually easy with these forceps just to grasp you need quite a high power under the microscope, grasp the posterior capsule, and you can see it tearing quite easily. In children, the anterior hyaloid is very firm, so you very rarely get problems with vitreous coming forward unless you are very rough with your instruments and you break the anterior hyaloid face. But even then, it's a much more solid gel than it is in an adult, so there's not usually a problem with vitreous prolapse in young children. I agree, take the fragment out of the eye. In adults, it's really important because if you leave a fragment of anterior capsule in there, it causes a fantastic uveitis the next day. So always remove it to make sure it's out of the eye. And then the lens goes into the capsular bag. Now, this is sometimes the cause of one of the complications. Sometimes the way that some of these lenses go in children, it's quite easy to lose it into the vitreous cavity if you do the rhexis before you put the lens in. So another option is to put the lens in first while the posterior capsule is still intact, and then do the posterior primary rhexis underneath the implant, and that makes sure you don't dislocate the lens backwards. It's a bit more tricky in terms of manipulating the capsule under the implant, but it does mean it's a bit safer and that the lens won't go backwards into the vitreous. And as I said, it can be done as part of an anterior vitrectomy. It's less controlled and, say, often a bit more irregular in children. So what about managing the posterior capsule tear during phacosurgery? You'll see in this video, is it possible to stop the video there? Can you just pause it or not? Can you do that? No, maybe not. Okay. You saw the phaco probe catch the posterior capsule. There's just a little tear there. And the problem here is that surgeon did exactly what you shouldn't do when you break the posterior capsule, just took the instruments out of the eye. And the vitreous pressure caused vitreous prolapse through that tiny hole. Now, while the phaco probe was still in the eye and the infusion was going, it was all tamponaded and it was all safe. And if the surgeon had left the irrigation running and had put viscoelastic in with the other hand and tamponaded that tear, he would then have been able, she would then have been able to do a very controlled posterior rhexis, and the vitreous face would have stayed back. But this is the natural reaction when you get a complication. You know, you panic, you take your instruments out of the eye. We'll talk a bit more about this in detail tomorrow when we talk about vitreous loss. And this happens, and once that's happened, and you've then got vitreous in the anterior segment, and you've got potential anterior-posterior traction when you manipulate it, the incidence of retinal detachment is now much higher. So an important concept when you're managing posterior capsule rupture in cataract surgery, leave the instruments in the eye, leave the irrigation going, do a viscoelastic fluid exchange, tamponade the posterior capsule, and then you're in a stable, safe situation. You can do a very controlled posterior rhexis, put the lens in, take the viscoelastic out, and you're home and dry. Complications, we've mentioned, you can tear out the posterior capsule in the same way as the anterior capsule. So we call it the Argentinian flag syndrome if it's stained with vision blue and a white cataract, because an Argentinian flag is blue, white, blue. I don't know what green, white, green is. Is there a flag like that? Which we might see, and the posterior capsule, of course, you haven't stained it, so there's no Argentinian flag. It's just a big rent, a big tear in the posterior capsule. And you can get vitreous into the AC if it's an adult. In a child, often it's not a problem. And as I say, you can put the IOL into the vitreous cavity. Some of these lenses unfold quite uncontrollably, and it's quite easy if you've done the posterior rhexis to just inject the lens into the posterior segment. You then have to phone up your friendly vitreoretinal surgeon and talk to them nicely, and buy them supper, and persuade them to take the lens out a bit later on. Just a word about identifying vitreous. This is one of my pet subjects. There are people in this world who think they can see vitreous. Hands up if you think you can see vitreous. It's usually vitreoretinal surgeons that think they can. But you can't. Your vitreous is invisible. You're all looking through your vitreous now at this screen, and you can't see it. And therefore, if you don't stain it somehow when you manage vitreous loss, you can't see it. So here's a video just demonstrating that. This is a patient with a lens coloboma. There's a capsule tension ring in place, so the coloboma has been supported. And at this point, triamcinolone is put into the eye when the cataract is removed. In these days, we were using undiluted triamcinolone. Nowadays, I dilute it 5:1 or 10:1, so it's not quite such a snowstorm as this. And when you wash it out, what's left is vitreous. And you can see all of that is vitreous. which was completely undetected by the surgeon at the time. And you could imagine if you try and do irrigation aspiration with that in the anterior segment, you're going to cause peripheral breaks in the retina and big problems for the patient. Again, this is an old video. Nowadays, we wouldn't do a vitrectomy this way. This is old-fashioned, but it did allow us to get the vitreous out, and then you can do irrigation aspiration safely. In this particular case, the surgeon then puts in another lot of triamcinolone once the irrigation aspiration is finished, just to be sure that the anterior segment is clear. And you'll see that once that's happened, there's actually more vitreous that's invisible to the naked eye. So it looks clear now, but once the triamcinolone is in, you'll see quite clearly when you wash it out that there's still strands of vitreous coming around the corner from where the lens coloboma was into the anterior segment. And again, if you put an implant into the eye with that sitting there, as you dial the implant round, you will catch the vitreous strands, you'll pull on the vitreous base, and you'll cause retinal breaks, which will cause a retinal detachment. So there, that's vitreous again completely invisible before the triamcinolone went in. One of my colleagues likens it to cloaking a ghost. So if you've got a ghost sitting next to you and you put a white sheet over it, you can see the shape of it. You all believe in ghosts, I'm sure. And this is the same. You can't see the triamcinolone until you cloak it and show it up with the triamcinolone. And now the lens centers very nicely. There's no vitreous in the anterior segment, and everybody's happy. So a very important concept to remember. So posterior rhexis is a useful technique for pediatric and some trauma surgery cases. It is essential in some cases, and I think you've got to know when to combine it with an anterior vitrectomy. We'll talk a bit about that tomorrow. And I think appropriate tools are really important. Cross-action forceps make it very easy and a tool to use. Thank you very much.